So, dear colleagues, good afternoon, and thank you for coming for today's session addressing the management of atrial fibrillation as easy as the ABC algorithm for AF management. My name is Tatjana Potpara. I'm from Belgrade, Serbia. I'm a professor of cardiology, and my narrowest area of research is atrial fibrillation. And I have a pleasure to co-chair this session with Professor Marco Proietti from Italy, who is also very much engaged in the research regarding atrial fibrillation. And he will be the first to present a holistic and integrated approach to AF management as easy as ABC. Marco, please.
Many thanks, Tanya. Colleagues, good afternoon. Then, as we know, atrial fibrillation is one of the major leading cardiovascular conditions we are looking at these days. It recognizes a large epidemiology with millions of people knowing to be affected currently, and with numbers projected still to steadily increase in the next 20 to 30 years. And as we also know, atrial fibrillation is associated with an increased risk of stroke, and also, and not less important, an increased risk of cardiovascular death and increased risk of all-cause death. Being such an important condition, atrial fibrillation has generated an impressive number of evidence in the last 20-30 years, with an increasing number of papers published speaking about AF. This led to a progressive changing in the evidence available and in the guidelines recommendation. As you can see in the slides, this is the timeline narrating the changes throughout the various editions of UK and European guidelines that in the last 10 years has been informed particularly by the release of the results of the RELY trial, Rocket IF, and Aristotle trial, and finally in 2013 the ENGAGE trial, with the introduction of the 4 NOACs to our clinical practice. What this implicated, as you can see in this slide, in this very nice study published in European Heart Journal, pulling together data from different UK registries, the authors of this paper have been able to show how throughout 10 years, going from 2006 to 2016, the progressive increase in the use of oral anticoagulant drugs, together with the progressive decrease in the use of antiplatelet agents that we know are not recommended for the treatment of thromboembolic risk in atrial fibrillation, led to a progressive decrease, in particular from 2012 onwards, in the rate of stroke and thromboembolic events. Then our sorry for the play, but our work succeeded in reducing the stroke risk. But what else? Atrial fibrillation patients are also burdened by an increased risk of death. Several data, both observational, as you can see on the left, and data retrieved from the NOAC trials, showed how the risk of death is very high, consistent, and even higher than the stroke and thromboembolic events risk. Even recently, in a paper we published together with Professor Boriani and Tanya and Professor Lip about the 1-year-long follow-up in the European Atrial Fibrillation Observational Long-Term Registry, we showed how all-cause death affected 5% of the patients, being the most often reported outcomes, despite a very good uptake in the use of oral anticoagulants, both PKA and NOACs. Also, it's important to underline how the all-cause death and cardiovascular death risk in atrial fibrillation patients is mediated and related to the presence of several different comorbidities. You can see from this analysis retrieved from the ROCKET-AF trial how several comorbidities are associated with both all-cause death and cardiovascular death. So the problem is not just the thromboembolic risk. What to do then? In the last years, the concept of integrated care about atrial fibrillation patients has progressively emerged. We can see here in a meta-analysis published 2-3 years ago from the Gallagher group, we can see how patients managed with an integrated care are favored in terms of all-cause death risk with a significant reduction in the occurrence of the event, and also are favored in the terms of the cardiovascular hospitalization. So an integrated care is able to significantly reduce the occurrence of such important outcomes. Then experts have highlighted how an integrated care should be the next step in the management of patients with atrial fibrillation. And as suggested by this summary from the 6th AFNet European Heart Rhythm Association Joint Consensus Conference, we should develop a model in which, while the patients are managed by the heart team in the moment in which is more needed, then can go back to the integrated AF clinic in which the cardiologist, together with the AF nurse and together with a lot of different specialists and experts, can manage together the patient. But the problem is how to actually operationalize this. Professor Lipp has recently proposed the ABC pathway as a way to operationalize and streamline the integrated care in atrial fibrillation patients. And it stands on 3 main pillars. The A, that means avoid stroke, in terms of optimizing at the best the use of oral anticoagulant drugs in reducing the stroke risk, and we will speak about this later. The B, better symptoms management regarding the use of rate and rhythm control at the best of we can do. Third, manage the C, cardiovascular and other comorbidities. That means managing both hypertension, but also diabetes, also the risk-related coronary artery disease, stroke risk, etc. In this first study, we tried to test the hypothesis that the ABC pathway could be efficient in terms of event reductions, and we performed this analysis on the AFFIRM study database. Basically, we retrospectively looked at those patients that were managed in a way resembling the ABC pathway, and we analyzed then more than 3,000 patients, and we found that an ABC adherent management was observed in 7% of patients. What was really interesting was the impact in terms of adverse events. As you can see in this first slide, the red line is the ABC adherent patients, while the green line is the non-ABC adherent patients. As you can see, those patients managed in a way resembling the ABC had a consistent, a very lower risk of the all-cause death occurrence, also of the composite outcome, putting together stroke and other major cardiovascular events. And also we found a significant reduction in terms of first hospitalization. Then we worked out the multivariate regression analysis. And as you can see here, patients managed with this integrated care resembling the ABC pathway had a strongly reduced risk of all-cause death, the composite outcome, also major bleeding, cardiovascular death. But as you can see here, the ABC management affected also the risk of CV hospitalization and also affected the number of days the patient spent into an hospitalization episode. We also looked at how the different criteria worked together And as you can see, even just putting together two at the time of the criteria, we had a significant reduction in most of the outcomes, in particular when we put together the avoiding stroke and the treating of the comorbidities. In another study, we also looked at how the different number of ABC criteria worked in respect to the outcomes. And as you can see in these slides, as higher number of ABC criteria we follow, as lower is the risk of having both all-cause death and composite outcome. Then, in another analysis performed on a smaller cohort of Italian patients, we can see how, again, the ABC group, meaning a group of patients managed in a way resembling the ABC pathway, have a very decreased risk for the major adverse cardiovascular events. And we also can see here, looking at the Kaplan-Meier curves, how all the three pillars are important in reducing the occurrence of major adverse cardiovascular events. Then another analysis appeared on thrombosis and hemostasis regarding the nationwide Korean health insurance database. And again, they analyzed how much were the patients managed in a way resembling the ABC, and they found out that the 15% of patients were managed in that way. And in this slide, we can see easily how the use of the ABC adherent strategy steadily reduced the risk of all the outcomes examined. And again, we can see how higher is the number of ABC criteria fulfilled, how lower is the risk of having an outcome. And this was clear also looking at several different subgroups. Then recently has been published the MAFA trial, in which the ABC system has been incorporated into a nationwide strategy of screening and detecting atrial fibrillation and next to manage patients with atrial fibrillation. As you can see here from the study design that has been presented recently at the last ESC meeting, patients that were captured having atrial fibrillation during the first phase of the project, during the screening phase, have been then randomized to receive usual care or to receive care based on the ABC model. And you can see here some examples of how the ABC management worked in this study. Basically, they developed an app through which they can manage the various pillars of the ABC. As you can see in this first slide, they reported indications to the patients and they monitored the INR levels or in general other factors affecting the efficacy and safety of oral anticoagulant treatment. Similarly, they managed and constantly checked the symptom management and the use of rate and rhythm control therapy. And also, at last, they used a multifaceted strategy regarding patient education and patient continuous management in order to improve the management of the comorbidities. You can see in this slide an example of how the patient have a constant communication with the doctors that continuously monitor them in order to prevent at the most the occurrence of adverse events and to manage all the various comorbidities. Then a first analysis has been presented during the ESC, and as you can see here in this interim analysis, the authors have been able to show a consistent reductions in all the outcomes considered during the study, we are now waiting for the final results of this study. So if we think at a modern way, a modern management for atrial fibrillation patients, we need to consider the ABC pathway through we can check and monitor and constantly manage the three main pillars of the atrial fibrillation patients' clinical history, together and paired with the so-called Birmingham three-step, through which we can identify low-risk patients and consider anticoagulation for those that need anticoagulations, and we address the bleeding risk and finally choose the right anticoagulant drugs for the patient. Then, concluding, we know how atrial fibrillation recognizes an increased risk of adverse events like stroke and death. A lot of work has been done in order to reduce the risk of stroke, but now we know that there is still a large residual risk of death that can be found in atrial fibrillation patients. And in the last years, we put a lot of attention regarding the use of an integrated management for atrial fibrillation patients, and atrial fibrillation better care pathway has been proposed to operationalize and streamline the implementation of this integrated care. The data available so far seem to suggest that a clinical management resembling ABC pathway is able to promote a significant reduction in the risk of all the major cardiovascular events. Many thanks. Yes.
Thank you, Marco, very much for this excellent overview of the integrated AF care management and the ABC system. I suggest that we have discussion after all presentations. We will be here for all your questions. And now Professor Fuat excused himself for personal reasons, so Professor Proietti is also going to present a component of the ABC system, A for avoid stroke with anticoagulation. So Marco, please continue.
Thanks. So as we said, the first pillar of the ABC is to avoid stroke using oral anticoagulant drugs. And as I said, the modern way of conceiving the management of atrial fibrillation patients is based on the ABC operationalizing the Birmingham three-step approach, in which we use CHA2DS2-VASc score in order to identify the risk, the thromboembolic risk in our patients. What guideline says? As you can see from this table that is quite massive but simple actually, the CHA2DS2-VASc score is used by the most of the current clinical guidelines, both in its original and some modified way, with the notable exception of the Canadian guidelines. And as you can see, oral anticoagulant treatment is recommended for all of those patients that have a significant risk. That means a CHA2DS2-VASc score of 2 for male patients and a CHA2DS2-VASc score of 3 for female patients. Also, we should know, and we have recommendations from several guidelines, that also in those patients with just one additional risk factor for stroke, we should consider oral anticoagulation. Regarding what treatment, all the guidelines are concordant to say that the NOC is preferred over VKA. First, I would like to make a point about the patients with just one additional stroke risk. Currently, there is quite a lot of discussion about this topic, because as you can see here, the various studies available regarding this topic are still controversial. As you probably know, we usually put a tipping point to consider or not consider anticoagulation in terms of risk of having a stroke. And usually the tipping point that is used nowadays is the 0.9% per year of having a stroke, risk of having a stroke. And as you can see here, the various studies that have been performed about this topic have shown controversial results, with some studies showing that patients with an additional stroke risk factor have a consistent significantly higher stroke risk, and other studies not showing this increased risk. There are some pros and cons regarding the use of oral anticoagulant drugs in these patients, and as you can see, there are a lot, and the most notably are the fact that regarding the pros, there are several risk factors for stroke that goes beyond CHA2DS2-VASc that usually should be considered. Also, we should take in mind that stroke risk is not static, but rather is really dynamic and it changes throughout the time. On the other side, we know that obviously in these patients, the risk of major bleed while being treated is not zero, and also that all the various CHA2DS2-VASc risk factors are not equal. And so we know that actually we still need more research done in this area. But then we do probably have some questions about the use of oral anticoagulant drugs, even though the guidelines seem so clear and so firm in recommending the treatment and recommending the choice of the NOAC over the VKA. For example, what is the OAC uptake? And also, what is about the use of VKAs that for so many years have assisted us in treating these patients? Also then, the problems about the choice of the NOAC and maintaining a good adherence to NOAC treatment. And at last, what is the impact of the non-CHA2DS2-VASc risk factors? As we look at the problem of the OAC uptake, we can see how in the last years, several studies have been concordant in showing how the use of OAC in general have progressively increased throughout time. As we can see here from the Garfield AF data, you can see how up to the fourth cohort in 2015, up to 70% of patients were treated with oral anticoagulant drugs compared to the nearly 60% at the beginning of the study. This was shown also by the Gloria IF study that showed how globally more than 80% of the patients were treated with an oral anticoagulant drugs, even though this changes across the various regions with different uptake throughout the various regions in which the study was conducted. We can see here how the Pinnacle Registry in the US captured the situation, showing how starting from around 50% of patients from the 2011 on, the number of patients treated with a NOAC has been progressively showed to be increased throughout time, in particular with a bigger proportion of patients treated with a NOAC and with less patients treated with a VKA. This was true also for other countries. This is an analysis I made with some colleagues in Italy, showing how even in Italy from 2002 to 2013, the number of patients progressively treated with an oral anticoagulant steadily increased. Then the biggest part seems to be played by the NOACs, but actually, as you have seen in the previous slides, still a big proportion of patients are treated with a VKA. In this case, we need to take in mind that having this big and in several cases, safest alternatives to the VKA, we need to be sure that our patients are properly managed with a VKA. So the most important issue in treating a patient with a VKA is represented today by obtaining a good time in therapeutic range. As we know from the guidelines, it's important that a patient treated with a VKA reach at least the 70% of the time in being in the therapeutic range to be protected both from stroke and major bleeding. As you can see here in these slides taken from a meta-analysis published in PLOS ONE, in particular, the effect is important regarding the risk of major bleeding. What about the various NOACs? What about the choice? There have been several analyses showing indirect comparisons between the NOACs. We don't have a study comparing them directly today, but we still can take some important data looking at these studies. This is probably one of the most recent, published recently by Professor Lippinstroke, that looked at the biggest database regarding insurance data of AF patients treated with NOACs. We can see how really relevantly using apixaban seems to give to the patients the best balance between efficacy and safety. As you can see at the top of the graph, apixaban seems to be more effective compared to the bigatran in reducing the risk of stroke, and also even regarding the risk of major bleeding, apixaban seems to be the best choice. On the last part of the graph, also you can see how the bigatran seems to be better, works better than rivaroxaban in terms again of stroke risk and major bleeding risk. Actually, this data, similar data, have been shown from different studies, and what is important to underline is that all the observational studies in general have documented how all the NOACs works very good in the real life, and all the NOACs presented results in the observational studies very similar to those reported in the trials. But what is important to underline is that the various drugs showed different numbers needed to treat and numbers needed to harm, very likely related to the different type of patients that have been treated with the different drugs. So the most important message is that we need to look at the specific patient, trying to personalize the choice of the oral anticoagulant and the choice of the NOAC regarding several different issues. In particular, one of the most important is the renal function. As you can see here in this picture taken from the 2018 European Arrhythmia Association Guide to NOACs, it's important to take in mind that the choice of the NOAC and the choice of the dose is strictly related to the renal function, and also even the hepatic function have a great influence regarding the choice of the drug and regarding the choice of the dose. And the dose issue is a very big problem today, because as you can see here, we have precise and very strict rules to follow to take the decision of using a reduced dose of an NOAC. Notwithstanding, all the studies seems to be concordant, showing that a big proportion of patients are treated with the reduced dose, even though they don't have the criteria we need to prescribe this reduced dose. And this is a very important issue, because those patients have still an increased risk of stroke, and they are only just receiving the wrong drug dose, because they are not longer protected by that treatment. Also, another big problem is the persistence of treatment and the adherence to the treatment. As you can see here in this nice work that has been very recently published in the Korean Cardiovascular Journal, you can see how throughout time all the studies seems to document an important reduction in the persistence of treatment. That means that up to 24-30 months, a big proportion of our patients that have been prescribed because they need the treatment does no longer take that treatment. And also, even though the data are less numerous, you can see how throughout time, even the adherence to the treatment, meaning the number of times the patient remember to take the drugs he should take, is definitely impressive, documenting how a lot of patients are no longer taking their drugs regularly, as has been reported even earlier in time with this systematic review published in Thrombosis and Hemostasis, showing how in different studies, in different countries, the problem of adherence and persistence is a very big problem. Lastly, we should take in mind that other factors are important. For example, other clinical risk factors as the presence of chronic kidney disease or the problem of untreated obstructive sleep apnea or chronic obstructive pulmonary disease. Also, we know that there are a lot of data about the serum biomarkers that can help informing with more detail the risk of stroke, and also other factors, both morphological and functional factors regarding the cardiac function, are really important to be taken in mind while we look at each of our patients. Concluding, we know that it's important to obtain an adequate control of the thromboembolic risk using oral anticoagulant drugs, and all the international guidelines recommend the use of OAC for all those patients that have a significant high thromboembolic risk. But even though there are still uncertainties regarding those patients with a moderate thromboembolic risk, and the use of NOACs nowadays is unanimously recommended with a high level of evidence, notwithstanding, we need to keep in mind that still VKA are used, and we need for those patients obtain the highest quality of the treatment. The uptake of OAC has increased over time, but a lot of problems still remain regarding the choice of NOAC that need to be prescribed to our patients, that need to take account of several factors, both strictly related to the patients, both related to our health systems. And despite this increase in the NOAC use, we need to still do a lot of efforts to improve the persistence and adherence of treatment. And it's still important to keep in mind that other factors are affecting the risk of stroke in our patients. Many thanks.
Thank you, Marco, very much. As I said, I think I'll start anyway. So my task would be to discuss a C component, that is comorbidity, cardiovascular risk factors management, and lifestyle changes in patients with atrial fibrillation. These are my conflict of interest, not so many of them. And before I go into details with the C component, I would like to stress out that this component of the management of atrial fibrillation patients is at least equally important as the first two. It complements stroke prevention and rhythm control, so it's very important to keep in mind the need for the risk assessment in your patient and advice on lifestyle modification, management of comorbidities and cardiovascular risk factors. This is because atrial fibrillation can be precipitated with different factors. It's a multifactorial disease, and what is particularly important is that these factors are not independent from each other. They interact, they facilitate each other, they potentiate each other. For example, if you look at the patient with obesity, obesity promotes development of obstructive sleep apnea, hypertension, diabetes. Then in turn, any of these diseases can promote hypertension and so forth. So management of these risk factors is very important, and the presence of risk factors is sort of dose dependent, as you can see in this slide, because even the presence of a borderline risk factor burden, just a borderline elevated cardiovascular risk factor significantly increases the risk of atrial fibrillation, lifetime risk of atrial fibrillation, and the risk is the highest in patients with one or more elevated cardiovascular risk factors. Factors considered in this analysis of the Birmingham heart study were smoking, alcohol consumption, body mass index, blood pressure, diabetes, and history of myocardial infarction or heart failure. So any of these, even in a borderline intensity, significantly increases the lifetime risk of atrial fibrillation. And hence it's very important to recognize, identify, and address all of these cardiovascular risk factors. And the best results in the prevention, primary prevention of atrial fibrillation could be achieved if we could address all components of the AF risk factor pyramid. However, it's not possible. I lost slide, and there it is. It's sorry. It is not always possible or convenient to address all the components, and on the population level, probably addressing lifestyle factors and modifying lifestyle habits would have the greatest impact on a population level on the prevention of atrial fibrillation, and all of these factors, if addressed, would help to shift the distribution of the AF risk in general to more optimal form, as you can see at the upper right-handed part of the slide. Atrial fibrillation risk factors induce structural changes in the myocardial tissue. They induce fibrosis, inflammation. They also induce various cellular, molecular changes. And this is why early in during the investigation of atrial fibrillation, a concept of AF, Baggett's AF, has been proposed, essentially suggesting that pathological process of abnormal electrophysiological activity of myocardium also affects its structure, remodeling left atrium and potentiating the conditions that favor the occurrence of atrial fibrillation. However, early in the treatment of atrial fibrillation, it became clear that it's not just remodeling caused by arrhythmia itself, but that there could be a second factor, something else that also influences the remodeling process in the atria, and that is risk factor influence. So on top of remodeling caused by arrhythmia itself, there is additional effect on left atrial myocardial structure and function caused by the presence of various comorbidities or cardiovascular risk factors, and that remodeling also potentiates the recurrent atrial fibrillation and disease progression to more persistent or permanent atrial fibrillation. So it is very important to modify lifestyle habits to address cardiovascular risk factors and comorbidities in order to prevent incident atrial fibrillation, but it's also important to address all these factors in patients already diagnosed with atrial fibrillation, because in a secondary prevention you can help, you can slow down the progression of the disease, you can decrease arrhythmia burden, and you can increase the duration of arrhythmia-free period in patients treated with rhythm control, as we will see later. Indeed, electroanatomical maps have shown that the presence of various comorbidities or cardiovascular risk factors do influence the structure and function and electrophysiological properties of myocardium. And also various studies showed the impact of various risk factors on AF-free intervals after treatments dedicated to rhythm control. For example, in a meta-analysis of the association of obesity with AF recurrence, it was shown that for every 5 units increase in body mass index, there was additional 10% risk in post-operative and even 13% risk in post-ablation setting for recurrent atrial fibrillation. So if you plan rhythm control to improve symptoms in your patients, it's very important to concomitantly identify and address factors that could also influence remodeling of the myocardium and progression of atrial fibrillation. Also, many other factors have been shown to affect recurrent atrial fibrillation and sinus rhythm maintenance. Also, the presence of obstructive sleep apnea increases the risk of recurrent atrial fibrillation as much as by 25%. So then again, in the course of the development of various treatments for atrial fibrillation, various therapeutic interventions have been developed to address and target AF risk factors to modify them in order to improve arrhythmia outcomes. And there are several recent studies that focused on aggressive risk factor management in the care or about obese or overweight patients. And these studies adopted a structured physician-driven, goal-directed programs that they used in their patients. And these were arrest and legacy studies. They were first to show the effects of such structured, multifaceted intervention that addressed the presence of overweight or obesity, hyperlipidemia, obstructive sleep apnea, hypertension, and diabetes. And what was shown in these trials was that compared to usual care, a structured management of risk factors significantly decreased the rates of recurrent AF or significantly increased the AF-free period after management of heart rhythm. And also on a long run, it has been shown that a persistent reduction in cardiovascular risk factors, in this case overweight and obesity, also significantly influences the success of rhythm control strategies. So again, it is very important to keep in mind these factors and to address them. It also has been shown that cardiorespiratory fitness is favorable in terms of likelihood of successful rhythm control. And also, if at the baseline, if cardiorespiratory fitness is not of a high quality, improvement in cardiorespiratory fitness during management can significantly improve patient outcomes and increase chances for successful rhythm control. And that is also something that should be kept in mind, and patients should be informed about that. The most recent publication addresses the importance of the glycemic control in diabetic patients undergoing AF ablation. So from the point of view of successful rhythm control, it is very important how blood sugar is controlled at baseline, which is shown at the left-handed panel. However, even more important is how the glycated hemoglobin has been controlled during the year before the procedure. So everything that patient had been sustained without management will have consequences in terms of increased remodeling of left atrium and increased risk of recurrent AF despite rhythm control management. It's very important to pay every attention to address and modify these risk factors. And this is a nice illustration provided by Prof. Sanders, summarizing the goals, what we need to achieve in our patient in order to make the best of the AF catheter ablation. So you need to think about weight regulation, glycemic control, obstructive sleep apnea, smoking, alcohol, hyperlipidemia, blood pressure regulation, and regular exercise. And these measures are important to help your patient benefit the most of AF ablation. And it has been shown that modifying these risk factors and changing lifestyle is also associated with decreased need for repeated AF ablation. It increases chances that first procedure will be successful on the long term. Now, these were studies investigating the impact of risk factor management on the maintenance of sinus rhythm. However, and also from the epidemiology studies, we know how various risk factors affect the occurrence of atrial fibrillation. But before reverse AF study, actually it was not investigated how risk factors and comorbidity management affects the disease progression. Is it possible that effective management of these risk factors could sort of reverse the disease back? And this is what reverse AF study investigated. This was observational study, not randomized. And you can see here that according they took weight reduction as a representative of a set of risk factor modifications that were performed during the study. And you can see that with increasing weight reduction, with increasingly optimal risk factor management, the proportion of patients free of arrhythmia after a rhythm control treatment was increasing, as well as the proportion of patients with reversed disease, with regression from, say, persistent to paroxysmal atrial fibrillation. And on the right-sided graph, you can see that among patients with the most optimal risk factor control, the percentage of patients with disease regression was as high as 88%, whereas the regression of disease was rather low and the progression was high among patients with not so good risk factor control, in those who either achieved a very small weight reduction or even gained weight during the study period. So again, it's very important to effectively, optimally modify risk factors. And finally, now we have a randomized clinical trial evidence that structured addressing and optimizing of various risk factors, at least in patients with AF and mild to moderate heart failure. Such patients were included in the RACE3 trial. Addressing risk factors and managing risk factors in such patients definitely significantly increases the proportion of patients free of arrhythmia at 1 year follow-up. So definitely we have, again, the highest quality evidence of the relevance of risk factor management. And also the RACE3 study showed that risk factor management also decreases the burden of AF. So if not completely abolishing recurrent AF, at least the number of recurrent episodes and their duration will be decreased by effective risk factor management concomitantly with various rhythm control therapies. Not to mention, and I'm not going to discuss that in the interest of time, that there are various comorbidities and cardiovascular risk factors that directly affect bleeding risk in patients taking oral anticoagulant therapy. So modifying these risk factors, you can also decrease the risk of bleeding in your patients. So dear colleagues, let me conclude, as I said, that risk factor management and management of cardiovascular comorbidities is at least as important as other two components of the ABC algorithm for management of AF patients. Lifestyle modification and cardiovascular risk factor management has been associated with decreased risk of incident AF, recurrent AF, and as well as arrhythmia progression and AF burden. Now we have solid proofs that it is very important to address these risk factors and manage them. However, we need more data to realize how to best implement such interventions in daily clinical practice. Thank you.
And thanks, Tanya, for the brilliant intervention. And now we are ready for Dr. Hulla. As we said, that is a consultant cardiologist in Southampton that is speaking us about the better symptom management with rate and rate control. Please.
Oh, okay. Hey, hello. So it's working. So hi, I'm Dr. Lime from Southampton. I'm going to be speaking about better symptom management with rate or rhythm control. This is part B of the ABC to AF, as you've all gathered. So in terms of outline, we're going to talk about the actual symptom burden in atrial fibrillation, who gets symptoms, and what the impact of rate control is and what the impact of rhythm control is on symptoms. So first of all, what we're not going to be talking about is hard endpoints like mortality. So just briefly, this is a sort of meta-analysis of all the rate versus rhythm control trials from way back, showing no difference in those trials between rate and rhythm control and mortality. This is Castle AF showing a benefit for ablation in heart failure patients in terms of mortality. And this is, this is looking at the Cabana data sort of sideways and showing a mortality benefit if you do a per protocol analysis for AF. But that's not the topic of this talk. This is actually all about quality of life. So while AF is associated with hard endpoints like death, stroke, hospitalization, and heart failure, there's a lot of other endpoints which have a lot of significant impact to our patients. And these are really based on symptoms. So things like palpitations, breathlessness, fatigue, low mood, cognitive impairment some patients feel as well. And really the way of quantifying this is quality of life scores, because I can take all of these sort of more nebulous things and combine them together into a sort of quantifiable score, which helps us in terms of research protocols. So does AF affect quality of life? Well, there's some data on this. This is from 2000. We have a sort of little study here with 152 patients with AF, and they are significantly worse parameters in terms of global life satisfaction, functional capacity, symptom frequency, compared to patients who are healthy subjects, and actually comparable to patients who had angioplasty recently. So AF patients have quite a burden of symptoms in this study. And the other study on the right-hand side here, you've got some bar charts here. These are showing each bar is a different component of the SF36 score, which is a sort of quality of life score. So the white bars are patients with AF, and the solid bars, solid bars are patients with AF, and the white bars are patients who are age-matched healthy controls. And you can see that patients with AF do worse for pretty much every parameter, whether that's general health, physical functioning. Physical role they don't do any worse on, but bodily pain, funnily enough, they do worse on. And mental health is similar, social functioning is a bit worse, and the emotional sort of component of the SF36 is worse as well as vitality. So a lot of different aspects of quality of life scores are affected by atrial fibrillation. I would say there is a paucity of high quality of data with this. So no one's really done a cross-sectional large study where they've matched control patients to AF patients, and that's matched them in terms of comorbidity. So it could be that AF patients have a lot of hypertension or heart disease or heart failure, and these studies unfortunately aren't picking that up. But we all feel that AF has a big symptom burden, and so that fits with our narrative anyway, to believe this data as it is. So the next question is, you get patients who've got no symptoms from atrial fibrillation, you get patients who are highly symptomatic from atrial fibrillation. So what's the difference? So there's been a recent study from the Kalman group in Australia, and they looked at 78 AF patients, and they assessed AF-specific and physical health-related quality of life questionnaires scores, and they compared a lot of factors. So they compared the gender, because there is some intimation in the literature that women are more symptomatic, although I would say that most studies contain a lot of men, so it's very hard to tease that out statistically. The type of AF, whether it's persistent, paroxysmal, the burden of AF. So a lot of patients here, I think all of them actually had loop recorders in, so you actually know the percentage burden of these patients. Whether they had sleep apnea, how old the patient was, the BMI, echo parameters, lots of other parameters as well. But they also interestingly include the perceived stress scale. So this is the degree to which subjects or patients felt that events in the last month were stressful, or how they sort of interpreted subjective experience in their lives, and what their support networks were. And also, they also looked at type D personality traits, so how likely people were to look negatively on a situation, negative affect, and social inhibition. And in fact, when you include all of those in multivariate analysis, and this does project, so if you look at the AFSS, so that's the symptom score, that's the top half of this box here. So the perceived stress scale and the type D personality scale are the only things which actually were significantly related to people having symptoms in terms of the AF symptom severity score and also the SF36. Now, so that, I mean, I guess that's putting a psychological spin on who gets symptoms from atrial fibrillation. So it's not what their AF burden is or their gender, it's actually what kind of personality type they have. But I would spin that round and say perhaps the fact that they have lots of symptoms from AF is making them have a more negative outlook. So I don't think it's that easy, nothing really is in psychiatry or psychological studies, but regardless, that's very interesting work. But then the other interesting thing is symptomatic versus asymptomatic episodes. So this group looked at 233 PAF patients, and they did daily ECGs in these patients, and also when the patients had AF symptoms, or what they perceive to be AF symptoms, they'd also do an ECG as well at that stage. And they looked at 3 parameters on this AF lifestyle quality of life questionnaire. So parameter 1 is subjective symptom frequency, so how often they think they're getting symptoms. Parameter 2 is the severity of the symptoms, so how bad the symptoms are. And 3 is how limited they are in terms of mental anxiety from these symptoms. First of all, it's important to say that there's no relationship between the amount of symptomatic episodes with people who are having an asymptomatic episode. There's no correlation there. But interestingly, if you look at the end of 1 year of follow-up, patients who had predominantly asymptomatic episodes correlated with patients' own perception of the severity of the symptoms of AF and the limitation of their activities and mental anxiety. So the actual symptomatic episodes also correlated. So if you have lots of symptomatic episodes, you have very low scores in terms of how anxious you are and how severe your symptoms are. But on the other hand, if you have lots of asymptomatic episodes, while you don't feel that you're having lots of subjective symptoms, you do have a general lowering of your actual quality of life. So you've got more perception of severity and more perception of a limitation of activities and anxiety. So even having asymptomatic episodes of AF seems to matter to quality of life. So taking this a step further, if you look at patients who just have asymptomatic AF, so the other patients had mixtures of symptomatic and asymptomatic episodes. But this was a small study where they looked at the quality of life questionnaires in patients who, in group 1, were essentially asymptomatic from atrial fibrillation. So they had none of the usual stuff, no palpitations, dyspnea, dizziness, exercise intolerance, chest discomfort. And they compared them to group 2 in this table, which are patients who had symptomatic AF. Actually, if you look right at the bottom here, patients with asymptomatic AF had a worse perception of their general health and a worse perception of their global life satisfaction. So even in patients who have no symptoms of atrial fibrillation, they have worse quality of life scores. And that may just be the diagnosis, the label of atrial fibrillation, which is making them feel worse, or it could genuinely be an effect of atrial fibrillation beyond just palpitations, breathlessness, etc. So the other interesting thing in terms of symptoms from AF is dementia. So in 2012, these guys have done a meta-analysis of 8 studies. These are all patients, 77,000 patients who've not had strokes, who were normal cognitive function at baseline. They followed them up for about 7.7 years in all these studies combined. And if you look, there is a relationship with an increased rate of dementia and having atrial fibrillation. So the mechanism for this, there's a very nice review on this, and it could just be that it's systemic inflammation, cerebral small vessel disease, cerebral hyperperfusion. We don't exactly know the mechanism, but there is a link between AF and developing dementia. And then that goes on to cognition, to cognitive symptoms. So this German group looked at 87 patients who'd not had strokes, and they compared them with, they've got AF, and they compared them with patients who've not got atrial fibrillation. And they found, now this table I won't go into in detail, but actually, if you look at learning and memory and attention and executive functions, there's a significant impairment in people who've got atrial fibrillation in those parameters. And similarly in this group, this is a massive study, and there was about 4,000 patients without AF, 330 with AF, and memory is significantly impaired in the patients with atrial fibrillation, even if you take into account other things like age, education level, stress, etc., gender, etc. The other, there's actual structural correlates as well. So the hippocampi in patients with atrial fibrillation were found to be smaller, and actually the total brain volume is actually smaller in patients with atrial fibrillation as well, and it seems to linearly correlate with patients who had atrial fibrillation longer, and that's white matter and grey matter volumes as well. So, AF causes more subtle symptoms than we sort of appreciate in terms of cognitive function as well. So how can we improve it? So how can we go into B of the ABC? Well, there's different things we can do. We can do lifestyle, even to improve these symptomatic episodes. There's rate and rhythm control, non-ablative. There's pace and ablate strategies, and there's AF ablation as well. So the next slide it's a paper from Jack, and it's 49 PATH patients. This is a very eminent researcher, and these patients each had 3 months of measuring their symptoms. And this is, again, daily ECGs, and if they have symptoms, they had ECGs that are done at the same time. And then 3 months after yoga training, they had the same scores taken again. I know, but it's in Jack, and it's very believable. So if you look at the actual bar chart here, so symptomatic AF episodes is when patients felt they had AF and they did an ECG and they had AF. Asymptomatic episodes was where they thought they had AF, but actually their ECG didn't show AF. And asymptomatic AF is just picked up on their daily ECGs, which they had to do. And you can see post-yoga training, in green, there's a significant reduction in both symptomatic, asymptomatic, and even completely asymptomatic episodes of atrial fibrillation. So something's happening here. And if we look at this table here, in terms of quality of life, so if you look at the penultimate column, which is post-yoga training, and compare it to, I suppose, pre-yoga training, which is the second column there, you can see that there's significant benefits from the yoga training in terms of physical functioning, anxiety scores, and depression, and even blood pressure improvements. And actually, the quality of life improvements for these patients didn't correlate with the reduction in the symptomatic episodes. They actually correlated with the reduction in anxiety scores and blood pressure. So it could be that the yoga training is lowering the blood pressure, and we know that blood pressure is a precipitant for AF. But that doesn't explain the reduction in anxiety scores. And so now Prof. Lip's team is actually doing a study at the moment, which is ongoing, looking at cognitive behavioural training and atrial fibrillation to see if that has an impact on symptomatic episodes and symptoms in general, and hard outcomes as well. So if we go back to conventional medicine, so looking at the original rate and rhythm control trials, they looked at how quality of life was affected by rate and rhythm control. And so this is an affirmed sub-study, 845 patients. As you all know, affirmed randomized patients either having rhythm control or rate control. And on these two bar charts we can see, so the vertical dark line on the top there, that's the average for people who have no AF who are healthy. And you can see already at baseline, the two bars, the white bar being rate control, the grey bar being rhythm control, are already lower. So the actual quality of life scores right at baseline are lower than age-matched controls in the US population. As you go along, you never actually hit the black line. So you never hit the general population level of quality of life. And actually there's no difference in rate and rhythm control in this trial. So I guess what this trial shows is you can improve things a little bit. So the black stars on top of the bars are slight improvements in your quality of life, but you never get back to the actual population mean for your quality of life, whether you use rhythm or rate control. And these are, remember, mainly pharmacological trials of both, so either amiodarone or rate control agents such as beta blockers. So if we go to another more eminent therapy, so pace and blate. So in this study by Natale et al., they looked at 75 rate-controlled AF patients. So the patients were rate-controlled to begin with, and then they either randomized them to pace and blate and stopping their rate-control medicines, pace and blate and continuing the rate-control medicines, or pace and just pacing, no ablation, and continuing the rate-control medications. So if we look here, this is looking at group 1, who had the medicine stopped and AV node ablation, and there's significant improvements in all these quality of life indicators for these patients. And actually you don't get as much of an improvement if you continue the rate control drugs. So this kind of suggests to me, so group 2 was where you continue the rate control drugs, but you had a pace and ablate. So this suggests to me that pace and ablate is valuable, but actually to get the most benefit in terms of improving quality of life, it's when you stop the actual rate controlling drugs, which makes sense, because we all know that rate control drugs such as beta blockers, etc., cause a lot of tiredness and a lot of side effects. So pace and ablate is valuable. So if we move on to ablation now, going to more modern therapy. So the Cabana trial, the primary outcome, as we know, wasn't successful in demonstrating a mortality benefit from intention to treat, but there's been a sub-analysis of the actual quality of life benefits from ablation. So again, there was about over 2,000 randomized patients with AF, and if we look over here, so in these two bars, or these two charts, are both looking at quality of life scores. So you have the vertical lines on both sides, which don't project very well, but if we look at the actual grey sort of diamonds at the bottom, you can see that diamond is very highly weighted towards favouring catheter ablation. So quality of life over this trial, looking at 5 years of follow-up, was significantly better in patients who had catheter ablation of atrial fibrillation rather than rate or rhythm control. I suppose one thing to note in this, which highlights one of the flaws of Cabana, is you can see in the beginning, so you've got the baseline squares over there, and then the next one there's quite a big improvement, then there's an even bigger jump to the next one, and then the actual benefit of catheter ablation seems to go back towards the middle. And the feeling from the writers of the paper is this is actually representing crossovers. So patients who are randomized to having AF or to having medical therapy crossed over to AF ablation, and they ended up having an improvement in the quality of life. But I guess overall the message from this is that the quality of life is certainly better if you do catheter ablation, whereas we know mortality, unfortunately, in intention to treat isn't. So I mentioned AF and cognition a bit earlier. So in terms of measures to improve cognition, well, warfarin has been found and statins have been found in very large retrospective studies to have a beneficial impact in terms of developing dementia in patients with atrial fibrillation. So that's one thing. So they may be protective, although no one's obviously studied this yet in prospective large studies. It's all registry data, but it's about 30% reduction in the warfarin trial, and around that level in statin trials. It may be even better for NOACs, because the problem with warfarin, as we know, is the time and therapeutic range. And so actually, if you have something like a NOAC where you've got a maximal amount of time and therapeutic range, you may be more protective. If you look at the affirmed data again, rate versus rhythm control, there was no significant difference in the mini mental state examination in those patients. So there wasn't a benefit in that trial between either group. If we look at catheter ablation, now this is something that's been recently published. So It's 150 patients who had an AF ablation. 50 of them were control patients. They were propensities matched. And if we look here, so this is the MOCA scores. This is the Montreal Cognitive Assessment Score. And the ablation group is in blue, the control group is in red. So the control group didn't have any ablation done. And you can see that 1 year post ablation for atrial fibrillation, there's actually there's an improvement in cognitive function. Whereas in the other group, the control group, the cognitive function is slowly declining. In the AF ablation group, it's actually significantly better. And interestingly, so this second graph is patients who, before the AF ablation procedure, had cognitive impairment. That's in dark blue. And the sort of lilac-y colour on the bottom is patients who had, the other way around. So the top line is no cognitive impairment to begin with. Bottom line is cognitive impairment to begin with. And actually, the patients with cognitive impairment had a more of an incremental benefit from AF ablation than the other patients. Now, this actually was dependent on the success from the actual ablation procedure. So if you look at bars A and B here, the more likely you were to be in sinus rhythm in the long term, the more you likely to have a beneficial effect in terms of your dementia or your MOCA score. Whereas the patients on the end in bar C had a sustained AF that recurred, and those guys didn't have as much of a benefit in their MOCA score. So it's not just doing the AF ablation, it's being successful with the AF ablation, which seems to be helpful in terms of cognitive function. So lastly, AF and heart failure. It's just briefly, this is a meta-analysis on AF and heart failure, AF ablation and heart failure trials, and this compares rhythm control versus medical therapy. And we can see here, this is a quality of life score measurement, and there is a significant, on meta-analysis, and a significant benefit to AF ablation in heart failure patients in terms of quality of life. This is notwithstanding the mortality benefits which Castle AF has shown, which you could dispute. There are obviously some holes in that study, but based on this meta-analysis on different studies, and it's only 164 patients, it's not big numbers, but certainly even in heart failure patients, there's a significant benefit in terms of quality of life. So, ladies and gentlemen, to conclude, so AF significantly impairs quality of life. And the impairment of quality of life may be related to personality indices. So it may just be that your patient who has symptoms has a specific personality type. And in that sense, non-medical interventions may actually help quality of life. So it may not just all be about our fancy drugs and our fancy ablation. It may be things like CBT or even yoga. Rate and rhythm control trials show no improvement in quality of life. So this is pharmacological rate versus pharmacological rhythm control. Ablation pace and AF ablation seem to improve quality of life, and there's pretty good data showing that. And there is actually a benefit, it looks like, from ablation on that small study, certainly, in terms of cognition for atrial fibrillation. Okay, thank you very much.
Many thanks. Now the last speaker, Dr. Gasbardi from Seattle, US, speaking to us about the importance of P-wave-centric ECG monitoring analysis. Please.
Professor Potpara, Proietti, ladies and gentlemen. So my goal today is to destabilize your conception of atrial fibrillation and make you uncomfortable with that diagnosis. Okay? So I'll start with some background regarding why this slide is important. Many of you think that ECG monitoring is routine. I can tell you there's nothing further from the truth than that. So let's begin with why. So I started a company on this because I lost my wife 7 years ago. She died of rhythm disorder, undiagnosed by multiple monitors. Note also, I'm an electrophysiologist for 39 years. I know my rhythms. I couldn't make heads or tails from the various rhythm monitors she had. So this is a personal vendetta against ECG monitoring as commonly presumed. So with that, you'll accept my biases. I started this company out of a vengeance, so to speak. So see if you can follow along as to why technology, we've heard this afternoon, multiple things affecting outcomes in atrial fibrillation. I'm going to add another, insecurity with the diagnosis of atrial fibrillation. So if you remember from the 1980s, Paul Taboul said the first thing that matters is the P wave. If you're looking at an ECG, you damn well better make sure you can see the atrial signal, or you have nothing when it comes to rhythm diagnosis. Many of you are unaware that the diagnosis of atrial fibrillation is predicated upon simplistic algorithms and even more simplistic artificial intelligence, which is indeed true to its word, artificial intelligence. So let's move from there. So would you accept half a chest X-ray? Probably not. No more than you would expect to make a diagnosis on rhythms from just the QRS. I mean, you need to see what's going on upstairs in order to know what's going on downstairs. So, no P wave, no rhythm diagnosis, and that includes atrial fibrillation. And you cannot reduce the world to AF yes or AF no. Cardiac rhythms are extraordinarily complex. Any electrophysiologist knows this. And to reduce it to this is, in my opinion, mindless. So let me introduce you to a herd of elephants that probably many of you are completely unaware of. So there are lots of them. Let's start with the biggest elephant. ECG monitors are designed to make the engineer's life easy. Repeat, they're designed for the engineers, not to make the rhythm clear. So the consequences of these rather unsavory engineering processes is you have no idea what the ECG really is as it emanates out from the heart, the analog signal. What is the analog signal? Not what the digitized signal is. What's the heart telling you? If you can't see the low amplitude, low frequency components of not only the P wave, the QRS and the T wave, you have nothing, because everything is embedded in not only the high amplitude, high frequency content, but the low amplitude, low frequency content. So, elephants, part one. I have three herds to go over. Here's the first herd. So when you look at this, clearly the P wave is not uniformly visible, no matter what the monitor is. If you use an algorithm to make a diagnosis and you can't see the P wave, the algorithms, which are essentially fast and irregular with a certain number of deltas on the RR interval over a certain number of beats, they've been around since the 1980s. They are useless then, and they're useless now. And what you may not assume is that they are not predicated on an understanding of the underlying rhythms. They're merely predicated upon RR interval variability. Thus, the massive overdiagnosis of atrial fibrillation in everything out there, including silly things like wristwatches. How can a neural network or artificial intelligence be valid if you can't see the P wave? Those are predicated upon QRS diagnostics of atrial fibrillation. Here's something that's quite weird. FDA approval of software. You have, all of you and all your institutions use software, yet you have no idea how that software is generated, and neither does the FDA or the CE marks. You have no idea how the software that is written. Who's it written by? It's certainly not written by cardiac electrophysiologists who understand rhythms. It's written by software engineers who are told to look after RR interval variability. They have zero comprehension of rhythms. I don't care where they are, under what company. They have no understanding. If you look at the rules for writing this software, the rules are predicated upon the MIT database, which is about 30 years old. If you ever see a study that says they're validated on the MIT database, immediately throw it away. It's useless, because the MIT database is useless. If you want to look at it, take a look into it in depth. Who teaches the writers of such software? No one. Most of that software was actually written in the 1960s. And it's been updated like an old house with patched windows and patched kitchens for the last 40 years. What are the understandings of anatomy and electrophysiology by these software writers? Zero. So I want you to understand, here's a very simple case in point. What is SVT? What does SVT mean? They don't know what SVT means, let alone the myriad number of rhythms that fall under that diagnosis. So when you see the term SVT, you can almost guarantee that no one knows what the hell they're doing, because all of you, and probably every one of the speakers today, had SVT in the form of sinus tachycardia. But very few of these diagnoses would ever pick up, let's just say, AV node reentry, or AV reciprocating tachycardia, or atrial flutter with variable conduction, or atrial tachycardia from the left atrial appendage. You don't see that diagnosis when you get this term, and that term is purely dedicated to rate over 100 beats per minute, which means essentially nothing. Here's another group of elephants. How are circuit boards designed? You probably all think that electronics is the same stuff in every one of your monitors. You have no idea how variable that is. You not only don't know how it's designed, you probably don't appreciate the incredible effect on the ECG by its design. Picking a capacitor, picking a resistor, how you pick your resistors, where you put your resistors, how do you put your controller, where do you put your integrated circuits. They all affect your ECG and whether or not you can see the P wave. That's a peculiarity you don't pay attention to, but it affects the outcome. What about just putting a straight conducting line down on ECG? You think that's nothing. You can just print circuit boards. That is not the way they're done. Those lines can be fat, they can be skinny, they can wave, they can touch each other. That also affects whether you have an electrocardiogram. This is perhaps boring information to you, but it touches upon whether you can go home with a diagnosis of atrial fibrillation. How they're manufactured, where they're manufactured, how are corners cut, how do you cut the costs of a circuit board? I can tell you, you cut the costs of a circuit board in one way, you lose the P wave. You cut it in another way, you might get noise. You cut it in another way, you might cut your costs for these two bare bones, but you don't deliver an electrocardiogram. The consequences for something like that are profound, and you don't pay any attention to that. Thus, again, my hypothesis, ECG monitoring is not a commodity. More elephants. Readers. Do you know what the education of a reader for life-threatening rhythm disorders is in the United States? 3 weeks. Your patients' lives are in the hands of high school graduates with 3 weeks of education. Do you know that if you have two types of software in the same reader on the same patient, you'll get two different reports? Do you know that if you give the same report to the same reader with the same software, you'll get two different reports. There are lots of factors like this that most of you are unaware of. The implication is you think you're getting truth, but nothing could be further from the truth. I know time is running out, but let me get back to the P wave in other ways. Not every rhythm that is irregularly irregular is AFib. Now let me just bolt through a host of issues. First of all, I put together a design that's based upon pulling out the low amplitude, low frequency components. And if you think that's easy, take a look at the first bullet. 64 patents to do that. That's more patents than are present in the entire ECG monitoring industry combined. It's not easy to see the P wave. It's weird, it's complicated, and it affects multiple factors. The bottom two bullets point something out. Readers are important. They must know their rhythms, and it has to be intense and deep. If you don't know your rhythms, you shouldn't, and like an electrophysiologist, you should not be reading people's tracings. So I'm just going to zip through a bunch of reports. Take a look at this sinus tachycardia at the top. It's a near field view of a rhythm. There's an intermediate, medium field view, and then a 40-minute beat-to-beat RR plot. But as I go through a bunch of tracings to emphasize the point that not all atrial fibrillation is atrial fibrillation, focus on this format because this is a format that I've put together. So here's a case in point. That's an irregular rhythm, but that's actual sustained atrial bigeminy. And if you can see the details of the P waves in that rhythm, you can see there are two different rhythms. The RR plot emphasizes that. This is sinus to atrial fibrillation with a classic irregularity of the baseline. So this is a good reference point on how you get to an atrial fibrillation diagnosis, typical AF cloud. This, however, is atrial flutter deteriorating to atrial fibrillation. This lead is AVF type lead, typical 2-to-1 sawtooth pattern. Would you do a pulmonary vein isolation on this patient? If that were me, I'd want you to take out my isthmus first, thank you very much, before you put me at risk for a pulmonary vein perforation or an esophageal fistula. Another case, variable atrial flutter with 2-to-1 flutter and then variable flutter. That's fixed atrial flutter. That too is not atrial fibrillation. Here's a fixed rhythm, which is atrial flutter and 4-to-1 conduction with oversensing of the P waves. Here's atrial tachycardia, diagnosed as atrial fibrillation with variable conduction. That's not atrial flutter, and it's not atrial fibrillation. Here's a patient with both, flutter again, bradyarrhythmias, and atrial fibrillation, going in and out of them. This is interesting. This is something most of you may have trouble recognizing, and it's only revealed by the RR plot. Atrial fibrillation with complete heart block, all right, with the junctional rate on the left shown on the RR plot. Atrial tachycardia with variable conduction here, 4 to 3 and 5 to 4 Wenckebach. Here's AT with an autonomic pulsivity to it. That's also irregular. That's not atrial fibrillation. Here's AV node reentry going off and on, off and on, off and on. That's not atrial fibrillation, but it's quite irregular. Classic AV-NRT with a PR jump and retrograde P waves. Here's right ventricular outflow tract tachycardia that could easily be misdiagnosed on these algorithms as AFib. And here's a simple review of the number of paroxysmal AF cases that I've looked at, 530. Only 42% have one rhythm disorder of atrial fibrillation. The rest have multiple other rhythm disorders. So every one of your AF patients should be suspected of having multiple rhythm disorders. Comparative data against a Holter, just a case in point. If you can't see the P wave, the bottom one is the Holter, you misdiagnose it as some sort of sinus tachycardia. The top tracing, clearly it's 2-to-1 AT. If you're not looking at the P waves well, you can take atrial fibrillation on the right and misdiagnose it as what it really is, which is 3 different disorders, AF, A-flutter, and AT. Those are different diseases with different management. So VT, same thing, no low frequency component, top tracings VT, bottom tracing misdiagnosed as AF. Same thing again here, low frequency components bring out the clarity of the signal. So, can AI be used for AF? Only with low frequency, low amplitude ECG data? Case in point, 9 different rhythms misdiagnosed, 7 of which misdiagnosed as AF on AI that does not include the P wave. So, let me conclude. No low frequency, no low amplitude ECG data, you don't have a diagnosis. And if you don't have a proper rhythm diagnosis, you really can't manage the patient with drugs, devices, or ablation. So I'll conclude with the statement I started with, ECG monitoring is not a commodity. Thank you.
Thank you very much for this very interesting and refreshing view. And are there any questions from the floor? While you are thinking about, yeah, please.
Two points. Is it as well surprising that in such an important subject we don't have any randomized controlled clinical trials of anticoagulation in patients with low risk atrial fibrillation? And I think it's amazing that so many people are now uniformly recommending that we should consider anticoagulation in people with a CHA2DS2-VASc score of 1, and yet there's not a single as far as I know, randomized controlled trial showing that it's beneficial. It seems quite extraordinary. And one wonders whether commercial interests have taken over from actual patient care in that context.
Yeah, actually, the problem regarding that topic is that even the analyses that have been made starting from epidemiological studies or cohort studies have been questioned by several authors because of the inclusion and exclusion criteria. And also, given the dynamic nature of the thromboembolic risk, could it be difficult to elaborate a study that look to those kind of patients? Because, for example, making a short example, if you have a patient that is hypertensive and is 62 years old and doesn't have any other risk factor and is a male, you got the CHA2DS2-VASc1. But in 2 years, that patient is turning 65, and maybe in the meantime, given to the hypertension, he develops progressively a heart failure, and he can very easily and very fastly turn into a CHA2DS2-VASc3. That would mean to have the right CHA2DS2-VASc, we could say right, to be prescribed with an OX. So probably it could be very difficult to operationalize a study like that. I don't know if Tanya would like to add something.
On top of that, I would say that patients who are at truly low risk of stroke, those with no non-sex related stroke risk factors, they do have so low stroke rates that it would take more than 50,000 of patients to be randomized to have a study which would be powered to show difference. The other thing is that we cannot conclude from published stroke rates regarding patients with a single non-sex related stroke risk factor, because I think you are alluding to this subset. if you look at the methodology of the observational studies or registry data, how they reported data, then you will see that in some studies, actually, that group was a mix of female patients having CHA2DS1 only because they are females, and we know that females' sex is not really independent stroke risk factor. It's rather a modifier and has interaction only in the presence of additional stroke risk factors. And on the other hand, males who really do have a single stroke risk factor, independent stroke risk factor. So no wonder that in such mixed cohort, stroke rates would appear to be low. Then again, some of the authors also did a sort of conditioning on the future because they excluded patients who were ever taking oral anticoagulant therapy, who were prescribed oral anticoagulant therapy, and included in follow-up only those patients with a single stroke risk factors who never received oral anticoagulant. That's a selection bias, and because probably the lowest risk patients were that way selected to be followed up. So at the end of the day, it's very unlikely that randomized trial on patients with a single stroke risk factor will be conducted. It would be too expensive, and as Marco said, probably unethical. But a decision should be made in every single patient, also taking into account some non-CHA2DS1 stroke risk factors, such as, for example, left atrial thrombus, or smoke in the left atrium, or decreased creatinine clearance, not qualifying yet for, moderate chronic kidney disease, and also patient preferences and personal values.
Thank you. I think this really shows that the CHA2DS1 scoring at the low end is not a useful parameter for making that decision.
Well, why do you think that?
Well, because if you can't test it, it can't be making much difference. You're saying that it's impossible to run a trial to show that it would point to a benefit in anticoagulant treatment, and yet we are recommending that people should be treated on that basis. It seems strange.
Yeah, but a CHA2DS1 score is not meant to actually predict who will get event. It's meant to simplify daily practice. It's meant to identify those who merit oral anticoagulant therapy. And those who are at the lowest end, those without CHA2DS1 stroke risk factors, in general, they do not need oral anticoagulant therapy. But of course, among them, probably biomarkers or some other imaging marker could identify a few more who would merit oral anticoagulant therapy. I agree.
Thank you.
If I can add a bit about that, also, even if a patient is truly low risk and then we say we don't start ARC at that moment, obviously that is not absolute. So we need to know that the patient will be followed in the future, because we need to understand when is the right moment to start an oral anticoagulant, because it will be a right moment when to start the treatment. And also, as a general comment about the use of the scores, we should try to move from a score-centric practice to a more comprehensive clinical evaluation with which while using the scores to inform our decision, but at last we should be the one that actually make the decision. So use the scores, but not just the scores.
Yes, I completely agree with that. Thank you. Yes.
Any other question from the floor?
Can I make one other question? It's not a question really, just to comment on Dr. Bardi's talk. I think it's very refreshing to hear the real difficulties with technology that we assume don't exist as cardiologists. I'm a bit unusual in that I spent 3 years studying signal processing before I went into cardiology, and I recognise many of the things that Dr. Bardi's been saying as being factors that my colleagues really know nothing about, and it's very good to hear it in this session.